And then before we get started, I just need to go over a few disclaimers. One is that I wanted to let everyone know that CME credits are available for this series. And with that in mind, we will be sending an evaluation after the webinar, and we would really appreciate it if you could fill it out. I also want to let everyone know that none of the planners or the presenter has anything to disclose. And now I will introduce our speaker. So Dr. Gallo is a registered dietitian with expertise in maternal and infant nutrition. She completed her training in human nutrition and dietetics at McGill University in Montreal, Canada, and she's currently an associate professor in the Department of Nutritional Sciences at the University of Georgia. Dr. Gallo's research focuses on nutrition during the critical periods of development, spanning from pregnancy through childhood. She's conducted seminal work on infant vitamin D requirements and continues to explore adherence and the appropriateness of vitamin D recommendations during both pregnancy and infancy. She's also interested in the diets of young children and how these relate to healthy growth. She works with vulnerable populations, including those participating in the Supplemental Nutrition Assistance Program for Women, Infants, and Children, also known as WIC, and she currently serves as an associate editor for Public Health Nutrition and is a member of the Journal Committee for the Journal of Nutrition, Education, and Behavior. At UGA, she teaches courses in micronutrient nutrition and food and nutrition policy. So I am going to turn it over to Dr. Gallo.
Hey, hopefully you can all hear me. So thank you, Dr. Boulay, for the introduction and for the invitation to speak at this great seminar series. I've attended some of the sessions and they've been wonderful. So today I'm going to talk about my favorite topic, which is vitamin D recommendations for infants and pregnancy, and I'll highlight some of the research gaps and where I think we need future research. I've also just returned from the vitamin D workshop in this year. It was in Cork, Ireland, and so I'm very excited about some of the new research that's going on in this area, or actually some of the lack of research that still needs to be conducted. So hopefully I'll be able to share some of that with you. So these are my disclosures. I don't think any of these are relevant for this presentation. So Dr. Boulay gave a description of my background. So I am originally from Canada, from Montreal. I completed all of my training at McGill University. I'm also a registered dietitian. And after I finished my degree, my training was really in human nutrition. And during my training, I focused on infant vitamin D requirements. And I'll tell you a little bit about that during the talk. But when I finished my degree, I transitioned to a faculty position at George Mason University. This is in Virginia, but it's right outside of Washington, D.C. And it was part of a college of public health. And I wasn't trained in public health. So my research really expanded to be more public health focused. And it was also in close proximity to D.C. So I learned a lot about nutrition policy and policy in general. In 2020, a position became available at the University of Georgia, and so I applied, and this was successful. And I moved in 2020, right in the middle of the pandemic, although I didn't know it at that time. So it's been a few years that I'm here at UGA. And really one of the reasons why I came was to be able to pursue some of the research that I'm going to talk about today. So I've done a lot of different work over the last couple of years as a faculty researcher, mostly focused on pregnancy, infancy, and early childhood. I'm really interested in how nutrition during these critical periods of life can lead to the prevention of chronic diseases later on. And although I've done different types of work in this setting, my focus and the focus of today's talk is going to be on maternal and infant vitamin D recommendations. So these are the learning outcomes. I hope by the end of this session, you'll have a better understanding of vitamin D recommendations and requirements for these two groups, infants and pregnant women. I'm going to talk about some of the subgroups that are going to be at higher risk for vitamin D inadequacy, and then how you can help to support optimal vitamin D status, either through improved education as a clinician for your patients or through future research. So the talk is divided into 3 different sections. The first is going to focus on infants and infant vitamin D requirements, and I'll give you some background about how these were established. And then we'll transition to adherence with the current recommendations for infants. And the last part is probably the shortest, is going to talk about pregnancy or maternal vitamin D requirements, which is a new area for me, although I was trained and have done a lot more work on the infants. So before we get into infant vitamin D requirements, I want to give you a little bit of background about vitamin D. So this may take you back a few years to some of your basic biochemistry, but I think this is important for you to understand. So one of the sources of vitamin D can be through sun exposure. This is called endogenous vitamin D, but it's not as easy as or simple as this shows. So upon exposure to ultraviolet beta rays from the sun, a compound that's found in your skin called 7-D-hydroxycholesterol, this is derived from cholesterol, can be converted into pre-vitamin D3. And then this can be eventually converted into vitamin D3 or cholecalciferol. This is a process that is affected by a number of different factors. This includes age. As you age, your 7-D-hydroxycholesterol is going to decline in your skin. And so aging is a risk factor for vitamin D inadequacy. But other factors that affect this process, this ultraviolet beta ray exposure, are going to also affect an individual's ability to endogenously produce vitamin D. And I've listed some of these here. Skin pigmentation, I've highlighted this because I think this is an important group of the population that's going to be at higher risk. Individuals who have darker skin color are going to be able to not make as much vitamin D endogenously as compared to those that are lighter skin. And this is because of the melanin in an individual's skin. This is studies from the 1980s that have showed this pretty clearly. But this also translates to clinical consequences. In NHANES, national US survey of pregnant women, they found that Black women had about a 6-fold higher risk of vitamin D inadequacy as compared to white women. So this is a group that is going to be at higher risk just because of that inability to make vitamin D as easily as lighter-skinned individuals. So endogenous sources are a source of vitamin D, but these are it's not probably the safest or the most sustainable way to be able to get vitamin D or as a source of vitamin D. So most of us are going to rely on exogenous sources. And so this includes those that are found naturally in food sources. Salmon is going to be one of the best sources, although this varies by different species. But there's very few natural sources of vitamin D. You can find D3 in foods like salmon. D2, which is ergocalciferol, can be found in vegetarian sources like fungi. And most of us, however, will be getting our vitamin D through fortified food sources, such as dairy products and such as milk. Milk is a natural source of calcium, but it also is fortified with vitamin D. And so products that are derived from milk are going to be a good source of vitamin D. And lastly, some of us are going to need to rely on supplementation. In infants, this is an oral supplement, which you can see here. Most other supplements now can be found in either prenatal supplements or other sources. Regardless of whether you can make vitamin D endogenously or through exogenous sources, vitamin D or cholecalciferol is going to need to undergo 2 metabolism steps in order to form the biologically active form. So the first step occurs in the liver. It's a hydroxylation step in order to form 25-hydroxy vitamin D or calcidiol. And then another step in the kidney, so the second hydroxylation step to form 1,25-dihydroxy-D or calcitriol. This is the biologically active form of vitamin D. And this is the form that's going to be involved in bone health or classical functions in bone health. We also are starting to understand that this compound may also have non-calcemic functions. And I've listed some of these here. Most promising are probably involved in diabetes or blood pressure regulation and in muscle strength. However, although these are promising, we still don't have clinical trials that have supported some of these non-calcemic functions. And so most of our vitamin D recommendations are still going to be based on this function on bone health. So even though 125 or calcitriol is the biologically active form, in order to assess an individual's status, we usually measure 25 hydroxy vitamin D or calcidiol. Total 25 hydroxy D is probably the most common way that we assess an individual status, and it's because it reflects endogenous and exogenous sources, and it also is less tightly regulated than the biologically active form 125 dihydroxy D. So these are the dietary reference intakes. In 2011, these were updated by the Institute of Medicine. Now it's referred to as the National Academies of Science, Engineering, and Medicine. But the IOM, which these are nutrition guidelines that are harmonized between Canada and the United States, and these are set for essentially healthy individuals. You can see calcium and vitamin D recommendations are here. And for vitamin D, the recommended dietary allowance, this is usually the individual target level, is set about 600 international units for most groups, except for over 70, slightly higher at about 800 international units. But what you can also see is that for the infant age group, the committee was unable to establish a recommended dietary allowance or what's referred to as an estimated average requirement because we don't have health data on healthy infants. And so this is a group that it really has not been studied very well. The Institute of Medicine committee established what's called an adequate intake level, and essentially this is an educated guess on the amount of vitamin D that's necessary for this particular life stage group. And they established that 400 international units or 10 micrograms per day is going to be sufficient to achieve concentrations of 25 hydroxy D in a range that would be associated with bone health. So in order to be able to address this gap, my doctoral work really focused on an infant vitamin D dose response trial. This was in breastfed infants, where we wanted to identify what would be the appropriate dosage that would be necessary for the majority of breastfed infants over the first year of life. And this was to really address that gap that was identified in setting infant recommendations. So we use the IOM cutoff of 50 nanomolar or 20 nanograms per mil. So I'm going to go between these two different units of measurement just because different organizations will use different amounts, but 50 nanomolar is equal to about 20 nanograms per mil. During that time, experts had recommended a higher cutoff of about 75 nanomolar or 30 nanograms per mil, as they thought that this would be associated with some of those non-calcemic functions. And so we use both of these targets as part of our primary outcomes. We also included secondary outcomes to look at the safety of these higher doses, as well as bone mass as a clinical outcome in infants. So this was a randomized clinical trial. Infants were referred from the Montreal area. These were all healthy breastfeeding infants that were born to healthy mothers. And this study was conducted between 2007 and 2010. So infants were recruited at about 1 month of age, and they were randomly allocated to one of 4 different groups of vitamin D, 400, which is the current recommendation, 800, 1200, or 1600 international units of vitamin D daily. And then we saw the infants every month for the first 3 months, and then every 3 months until they were 1 year of age. So this is the flow diagram for the trial. We had 132 infants who participated in the study, and they were randomly allocated to one of those 4 dosage groups. We actually had pretty good follow-up at 12 months, about 74, 75% return for follow-up at 12 months of age. So the study, the safety monitoring committee for the study discontinued the highest dose group during the trial. This is because although there was no safety concerns related to this dose, I observed very high concentrations in this group and thought that was unnecessarily high. And so this group was eliminated about a year into the study. So in terms of our outcomes, we found the majority of the groups were able to, or actually all the groups were able to achieve vitamin D adequacy over the course of the study. So 400 across even the 1600 group. But only higher doses were able to achieve that higher cutoff that was established, that 75 nanomolar or 30 nanograms per mil cutoff that was established by some experts. And it's unclear what is the right cutoff, although currently we're still using the 50 nanomolar cutoff. So higher doses were necessary to achieve this concentration, but it may be unnecessarily high. There was no benefits to bone mineral content over the first year of age. We looked at different regional sites and whole body in the infants over the course of the year, and there was no differences across the dosage groups over time. So in summary, the main point of the study, or the main finding, was that 400 international units was sufficient for supporting 25-hydroxy concentrations that are associated with healthy infant bone mineralization. And I want to just reiterate that this was 400 international units given daily, and this was mostly a white population group, mostly Canadian, French Canadian children that were participating in our study. So it doesn't really address all of those groups, even those that may be at higher risk. We did follow the children at 3 years of age. This was after a year, they didn't receive supplementation. And additionally, we didn't find any additional benefits to bone health, even at follow-up. So there might not be benefits of giving higher doses of vitamin D to breastfed infants over the first year of life in terms of bone health. This was important study and is going to be used in setting guidelines. This was the European Food Safety Authority, which cited the study in order to update their upper intake levels for vitamin D in infants, and it is being used by other groups as well. And my colleagues at McGill continue to look at this issue. And one of the studies that they had done after I finished was a trial looking at infants' vitamin D status in a group that was given high versus the current dosage. But what I want to point out is that they did find benefits in terms of lean mass at 12 years of age. This is a modest benefit, but it just shows that there may be potential other non-bone health benefits of giving vitamin D or higher dose supplementation into breastfed infants. So this is a potential next future research. So the study have found, and current guidelines suggest giving an infant vitamin D supplement of 400 international units per day. But are infants actually adhering to this recommendation? And that's going to be the second part of this talk. So the American Academy of Pediatrics updated their guidelines in 2008 in terms of vitamin D recommendations, and they actually doubled their amount that was recommended to be in line with the Institute of Medicine recommendation of 400 international units per day. And so I just want to highlight the recommendation, because some people may be unclear on what it actually states. 400 supplemental vitamin D is recommended for all breastfed infants, and it should begin in the first few days of life, so immediately after hospital discharge, and should continue until those infants are able to achieve that amount through other dietary sources. And this is usually not until they're able to get a liter or 32 ounces of formula of vitamin D fortified formula per day. And the recommendation extends to other older children as well. If those are not able to achieve this amount through dietary sources, then they should continue to get a vitamin D supplement. So some research has suggested is trying to establish whether giving the vitamin D supplement indirectly to a breastfeeding mother may be another vehicle to get infants enough vitamin D. And this was a study that was conducted by colleagues at University of South Carolina. It was a very good clinical trial that randomized infants and their mothers to either a group that contained just 400 international units directly to the infant or higher doses of vitamin D indirectly to the mother. And what they found was that the mothers had to achieve or had to receive about 6,400 international units. That's above the upper limit for safety for mothers in order to be able to get the same amount that's found in 400 international units given directly to the infant. So although the researchers found that this dose was safe over their trial, this is currently not evidence-based. And so the current recommendation is still to give an infant a vitamin D supplement directly. And this is not a new recommendation. This recommendation has been around for decades. This is from the 1930s and 40s. Even at that time, we understood that giving vitamin D was necessary. This was usually through cod liver oil, which is a natural source of vitamin D. And this is for the protection of bones and to protect against bone diseases like rickets, which was a problem at that time. So nutritional rickets, the vitamin D deficiency is a leading cause of nutritional rickets. It can also be due to calcium deficiency, and it affects young children less than a year or less than 5 years of age, mostly. And although we've mostly eradicated cases of rickets in North America and Europe, especially in North America, because of the required fortification of dairy products, we still do see cases of nutritional rickets in these countries. And this is a review of the incidence of rickets or nutritional rickets in these different settings. What you can see is that there are subgroups that are at higher risk for nutritional rickets. This includes those that are darker skinned, so South Asians in the UK, as well as African or Black Americans in the United States are at higher risk, or in Canada, as well as immigrants. So those are usually the groups that have been identified at higher risk for rickets in these countries. And this is a case study that was published quite recently of a 23-year-old or 23-month-old girl from Delaware who had identified vitamin D deficiency rickets. And the main causes seem to be because she's darker skinned, but also because she was breastfed without adequate vitamin D supplementation. So we continue to support or recommend breastfeeding, which is optimal nutrition for infants, but we sometimes forget to recommend vitamin D supplementation. And if we're going to be promoting breastfeeding, this needs to be synonymous or go hand in hand. So we looked at adherence with vitamin D recommendations in the United States from a national survey. This is the WIC Infant and Toddler Feeding Practices Survey. It's a national survey of infants and their caregivers who are participating in the Federal Food Assistance WIC. So we looked at data from 2013 to 2015, and we found about a third of infants were actually meeting the current recommendation of 400 international units, and that's across the first year of life. This is very much in line with non-WIC infants. This is data from NHANES that shows the same percentage. About a third of infants, 1 in 3 infants, is getting the current recommendation, which has been the guideline for vitamin D in this country for decades. And this is very different than what we see in Canada. This is data, recent data from the Canadian Community Health Survey. It's similar to NHANES in Canada, and they found that 87% of mothers were providing a vitamin D supplement to their infants. and 83% were giving this daily as recommended. It's also, the rates in the United States differ from what we see in Europe, where most countries have pretty good adherence with vitamin D in the 80%. The only country that seems to be doing worse than the United States is the UK, which is about less than 20% adherence rate. And they actually have a problem with nutritional rickets, or have identified quite a few cases of nutritional rickets in this country. So these recommendations are not being adhered to, at least in the United States. And it's important to not just provide the supplement or provision of a supplement, but also education is key. And this is an older study, but they found that in families that were given or provided the vitamin D supplement plus had education, this had an effect on 25-hydroxy-D status in their infants. So it's important that we not only educate on what are the vitamin D recommendations, but also on how you can obtain it. So in the United States marketplace, different supplement formats are available. The old-fashioned way is through an alcohol-based supplement. This contains 400 international units per mil. Newer supplements are oil-based supplements, which you can see here on the right. This supplement contains 400 international units per drop, so it's a tiny amount. The mother can put it on her breast when she's breastfeeding. She can put it on her finger, so it's much easier to distribute. It's also important that we provide education that this is an approved Medicaid drug, although a prescription is necessary in order to fill this for families that are on Medicaid. So the question came to me as, well, are there any consequences or clinical consequences if only about a third of infants in the United States are actually getting not getting the supplementation? So will low infant vitamin D intakes have any clinical consequences? And we really don't know that, because NHANES does not collect infant biospecimens less than a year of age. And so we're not tracking this nationally to know if there is a risk for deficiency in that infant age group. So this is what we did in our study. We had a feasibility trial, which we conducted in Athens in a local pediatric clinic here. We recruited 65 healthy term infants from this clinic, and this was a cross-sectional study, and we tried to recruit infants equally across different age groups between 0 to 6 months of age and by infant feeding type. We measured serum 25-hydroxy-D using a dried blood spot that uses the infant heel or their finger in order to get a sample. So it's a tiny bit of blood. We collected dietary and supplemental vitamin D intake using a 24-hour recall. And we objectively assess skin pigmentation using what's called a spectral photometer. It's this device that's found here, and you can actually identify skin color more objectively using this measure. So these are some of the characteristics of those 65 infants that participated in our feasibility trial. The majority were Hispanic. As I mentioned, this was a clinic that was serving mostly a Medicaid population, so 83% were receiving some form of federal or state aid. We also had quite a few that were, about 1 in 5 that were food insecure, so this is a lower end of the income spectrum. We had equal numbers distributed by season. We also had quite diversity in terms of skin color type, which is classified using this Fitzpatrick scale. So this was important determinant in our study. So in terms of whether the caregivers were giving a vitamin D supplement to infants, about 35% said they were providing the supplement. So this is really in line with our WIC data, as well as those national trends. Only about 1 in 3 were giving the supplement. The majority of those who were giving the supplement were breastfed, but as I mentioned, those that are mixed feeding, so even if they're getting formula and breast milk, still likely need a vitamin D supplement, and those were less likely to get it. And the majority that were giving the supplement were giving it once a day as recommended. So these are our results in terms of the 25-hydroxy-D concentrations in the infants. What you can see in terms of age is that infants or newborns, these are infants less than 30 days, were born less than 30 days, had lower vitamin D status. 40% were at risk for inadequate status in this group as compared to the older infants. Breastfed and those that were mixed fed had lower status as compared to the formula fed infants. And there were also differences by skin color, with darker skinned individuals had lower status as compared to those who were considered very light or light, using that spectrophotometer to assess that skin color or skin pigmentation. And we looked at the variables that are associated with infant vitamin D status using a regression model, infant age, and the infant total vitamin D intake. So that's what usually is coming from formula. If this was an important predictor of status, but mother's status was also an important determinant. We measured mother's vitamin D status using that similar dried dried blood spot testing, and that was an important determinant of status. And so likely we need to intervene with infants either very much earlier on at discharge or hospital discharge, but possibly even earlier during pregnancy. And that is possibly the way to prevent any risks to the offspring, is by intervening or optimizing maternal vitamin D status during her pregnancy. And so that's really the last part of this talk, is related to pregnancy vitamin D requirements. So vitamin D deficiency during pregnancy can have significant effects, not just for the mother, the pregnancy, but also for the infants. It can lead to bone abnormalities in the mothers. It can increase risk of complications like gestational diabetes or preeclampsia. It is, of course, associated with bone abnormalities in the infant, including nutritional rickets. So if a mother is deficient during her pregnancy, it's likely the infant is going to be deficient at birth and also going to be at higher risk for bone diseases like rickets. And we're also starting to learn that low vitamin D deficiency in pregnancy can be associated with growth or infant growth. There's higher risk for preterm birth in those that are deficient, as well as small for gestational age. And this is some new data that's starting to suggest that a maternal status during her pregnancy can actually have cognitive outcomes or effects on the offspring. This was a national study that looked at maternal vitamin D status in her second trimester and found that there was effects on offspring IQ at 4 to 6 years of age. And so higher status was associated with higher IQ in this national sample. So there may be other benefits of vitamin D, such as on cognition. But even with this evidence, our current recommendations for vitamin D in pregnancy are actually not different in pregnant women as compared to non-pregnant women. And as from the first slide that I showed on the dietary reference intakes, the current recommendation for pregnant women is about 600 international units, which translates to about 15 micrograms per day. And this is pretty similar to what you see in Europe and other Nordic countries in Europe. So it's about 10 or 15, so 400 to 600 international units. And that's not different from the non-pregnant women. And recently, this is actually, I just learned about it at the workshop last week. The Endocrine Society came out with new clinical practice guidelines. I think it's probably was released in June, and they identified different groups that would be at need to get supplementation, vitamin D supplementation. And pregnancy was one of those groups that could benefit from vitamin D supplementation. Although the panel did not establish the amount of vitamin D that was necessary in supplementation, and that's because we don't have enough studies in pregnant women in order to be able to study the potential benefits. So that is a recommendation. So my colleagues in Ireland conducted a dose response trial. This is one of the few studies in pregnant women. And although they did not look at perinatal outcomes, they identified or wanted to identify the amount of vitamin D that was necessary in order to prevent bone diseases like nutritional rickets. We know that infant concentrations less than 30 nanomole per liter, or this is about 12 nanograms per mil, are associated with higher risk for nutritional rickets. And so they wanted to identify the amount of vitamin D supplementation that would be associated with concentrations, cord concentrations above this cutoff. What they found was that they need to establish in order to establish cord concentrations greater than 30, mothers during their last phase of pregnancy needed to have a concentration about 50 nanomoles per liter. And in their dose response trial, they identified that a serum concentration about 50 nanomoles per liter was associated with an intake that was about 28 or 30 micrograms per day. That's about 1,200 international units, and it's about double what is currently recommended as part of the dietary reference intakes, as well as other practice guidelines. So, and this amount was actually higher in winter than in summer. However, this was an Irish cohort of women, mostly lighter skinned individuals. It did not address those groups of the population that would be at higher risk, especially in the United States, such as darker skinned individuals. So this is the future research needs that's identified by the Endocrine Society as part of their review. We don't have adequately powered clinical trial that includes perinatal health outcomes, like we discussed in terms of pregnancy complications or offspring growth. And we don't have those studies, particularly in those groups that are at higher risk for deficiency, those with darker skin pigmentation, as well as those who are living with obesity. We know that women, especially pregnant women who have excess adiposity, are going to have lower vitamin D status, and it's not clear why, although it's likely because the vitamin D gets sequestered in adipose tissue. And so those two subgroups of the population are going to likely need higher amounts of vitamin D than what's currently recommended. And we don't have any evidence on how much is necessary. We also need studies that look at offspring outcomes, including cord status, but also childhood outcomes, possibly cognitive benefits. So we don't, so it's not recommended to test vitamin D status even in pregnant women. And this is part of the Endocrine Society, as well as other practice guidelines don't recommend screening because of the possibility of misclassification. But some researchers are working on developing a screening tool to identify low vitamin D status, or the women who may be at higher risk for low vitamin D status. And this is something that I'm interested in. Early pregnancy is probably the opportune time to intervene in these population groups. So that's when supplementation or higher dose supplementation should be given in order to prevent any effects on the offspring. And this is a screening tool that was developed by colleagues in Denmark. They're using this. It's a quick questionnaire. You can do this in less than a minute, and it can identify those that may be at higher risk for vitamin D deficiencies so that clinicians can then intervene to provide supplementation or further follow-up. Now, this group is currently validating the tool with their population, but we would need population-specific tools because we have different demographics in the United States. We also have very different fortification policies and supplementation intakes, and so we need population-based tools in order to be able to use something like this in our sample here. This is something that I'm interested in. So if you work with pregnant women, especially if you see them early on in pregnancy, we should consider collaborating, because this is the target population that we want to use for this study. So in summary, I think I'm good for time. So infant vitamin D supplementation, 400 international units is what is recommended for healthy breastfed infants. Although it's recommended to be giving this supplement daily, which is the problem in the United States. Approved adherence is going to be necessary, and it's going to take clinicians as well as caregivers to understand why it's necessary. Maternal vitamin D supplementation is likely out of date. We're currently recommending the same amount that's necessary for non-pregnant women, and our requirements or studies like the Irish study clearly show that recommendations or requirements are likely going to be double what's currently recommended daily. But we need those studies in those subgroups of the population, like darker skinned individuals, people that are living with obesity, in order to be able to set these guidelines and prevent offspring health outcomes or negative offspring health outcomes. So these are my acknowledgements. Of course, the participants and families that were part of these studies. Of course, all the student trainees, I haven't listed them all, but this would not be possible without them. And of course, the funding sources. And I've provided my contact information. If anyone wants additional information, I'm happy to share the slides, or I'm happy to talk about potential collaborations regarding these questions. So thank you.
Thank you so much, Dr. Gallo. We have plenty of time for questions. If anyone wants to unmute and ask their question or type it in the chat. Well, I have a question while we're waiting. So you mentioned that rates of supplementation of breastfed infants are pretty low. And I wondered if you had looked at, like, what are some barriers to supplementation? Like, why do some parents choose not to supplement? Is it lack of knowledge, or is it expensive, or what could be driving that? And if there are differences by certain sociodemographic characteristics of parents.
So we did look at that. We asked that in our local study here, as well as in our national survey. We know that parents are not giving the supplement, mostly because they're not being recommended to give it by their pediatrician or healthcare providers. And so that tends to be the main reason. So we don't know if there's differences, regional differences. It's possible that, infants in the lower southern states where endogenous production of vitamin D is a source of vitamin D, those may be less likely to recommend it as compared to those that are in more northern states, closer to Canada, where it's higher latitudes where this is recognized as a risk factor. So that is probably the biggest factor. Many of the parents were just unaware of the recommendation and didn't know that they needed to provide a supplement to their infants. So that's possibly what we need to work on.
Yeah. And what about the provider side? Do you know why they're not recommending it?
So it varies. So it seems like it's not clear whether, who's giving the supplement. Some of the research suggests that older physicians who may have experience or, recognize rickets may be more likely to recommend the supplement, but I don't think we know enough about that. So, the provider side is not clear, so I'm not sure.
A question. Hi, and thank you for a wonderful talk. A question, really a clarification. Looking at breastfed mothers, did it matter what the mom's vitamin D levels were? In other words, if mom's vitamin D level was normal, were infants, breastfed infants, still receiving too little vitamin D through breast milk?
We don't know. I think it likely will have an effect. So if mother's status is, it depends on where in the, I guess, where she falls, but likely if she's at the lower end of that, what we say that define as a healthy range, this could potentially put the infant at risk. And plus, if the infant is then breastfed and not getting the supplement, they're likely going to be at risk for deficiencies. So I don't think we know clearly who that is, but we do know that it's a risk factor. So maternal status is going to be an important predictor of infant status and can potentially put them at risk.
I would think that that would have significant kind of policy and outcome implications, because many women who breastfeed are assuming that they are doing the right things for their babies, because that's what we've been drumming into their heads. And given the issues around checking mom's vitamin D status, I mean, we have issues with payment, insurance reimbursements for screening people for vitamin D deficiency. I don't know, I just see a lot of policy implications. And the other policy implication is this, it requires a prescription to get the vitamin D supplementation for infants. That just seems like a barrier to me.
Yeah, and we thought that could be a barrier too. The cost of the supplement can be a barrier to families. A small supplement can be about $15 to $20, and that's for about a 3-month supply. So if it is covered through, if it should be covered through Medicaid, although there seems like there's barriers there, that can be a barrier to giving the supplements, the cost of the supplement, and getting the supplement. So yes, yeah, I think those are all important points. It's not recommended. Screening or testing for vitamin D status is not recommended across healthy populations. It's not currently recommended, and likely that won't change. But I think what we need is to identify those groups that are going to be at higher risk for deficiency and maybe target those groups. But we don't know who those clearly are yet.
Well, I can almost guarantee you, even if we identified those people who are likely at higher risk of vitamin D deficiency, but then don't test them, people don't usually respond the ways that we think they might to an unknown risk category. You see what I'm saying? I don't.
And that's why it's not, recommended right now. So I think, yeah, there's still a lot that we don't know before we start making, changing guidelines or practice guidelines.
Any more questions?
I have another comment if there's no other question.
Oh, sure, go ahead.
I'm from the Morehouse School of Medicine, and we have a largely Black population, and have a maternal health and pediatric service. And you mentioned research in this area. I think that this is an area that we could get interested in if there's a particular question that you'd like to collaborate with a OBGYN service, that this could be an area that would fit well into our research portfolio.
Thank you, Dr. Franklin. Yes, please send me your email. Maybe in the chat. I'd love to reach out because that is, I think, what we need to do next is to identify clinics that are serving this higher risk population to determine if there's even a problem there. And so I think that's kind of the next step for me. So I would love to connect with you.
Okay, well, I think we are done. Thank you so much, Dr. Gallo, for your presentation. And for everyone who attended, you will be getting an email with an evaluation. It's really quick. If you could fill it out, we would appreciate it so much. Thank you.